much for coming this afternoon. As I said, this is part of our regular seminar series at the Global Diversities and Inequalities Research Centre at London Metropolitan University. My name is Louise Ryan. I'm Senior Professor of Sociology and I'm Director of the Centre. And I'm joined here today by Dr. Maria Lopez, who's the Deputy Director. And we'll be fielding the questions as we go through today's session. If I could ask you please to mute your microphones to reduce echo and feedback. We will be allowing plenty of time for discussion and questions at the end, but we will have the speaker first for about 30 to 35 minutes. So if you have questions, please type them in the chat, and then we will also invite you to put your hand up. If you don't want to type a big long question in the chat, you can simply put your hand up, but we will hold back on all questions until after the speaker has presented. So this session is being recorded. I should just inform everybody that it's being recorded, and the recording will be made available afterwards on the website. So we're delighted today to have one of our colleagues from the School of Social Sciences and Professions, Maja Myhre. Am I pronouncing your surname correctly? Probably not, Maja, sorry.
That's okay, Louise. It's very tricky. It's Myhre. It's Norwegian. It's difficult.
Okay, Myhre. I should have asked you that before we started recording.
Oh, that's okay.
Myhre. So Maja is a colleague of ours in the department, and she is a senior lecturer. She teaches health and social care, and is a nurse, I believe, a nurse and a PhD candidate in health policy. And she'll be presenting today from her PhD project, and the title is Exploring Healthcare Professionals, the Role in Healthcare Assessing for Undocumented Migrants, a qualitative study of policy and practice in the Norwegian primary healthcare services. That's the title of her PhD. So Maja is going to speak today for approximately 30 to 35 minutes, and we'll have plenty of time for questions. So we're really looking forward to hearing your presentation today, Maja, and over to you.
Thank you, Louise, for that introduction. So welcome everyone, and thank you so much for coming. I see some colleagues' names and some students' names, so I really appreciate that. Thank you so much for coming. So I wanted to talk about my PhD project. It has been something I've been working on for a number of years, as I'm a part-time PhD student, and I was just, if you were in the room, chatting with Maria about that journey. When you're doing the PhD, as some here might be doing or have done or planning to do, any opportunity to talk about my research, I try to take, because it's something that cements learning for me, and also something that gives me an opportunity to, I guess, gain a deeper understanding of my own work when I'm kind of forced to explain it to other people. So I really appreciate that, and I try to change up my presentations every time, so I'm kind of focusing on different things. And today I wanted to talk about kind of where I am with my initial findings. So I've produced some kind of initial ideas about my data so far that I wanted to present here today. So I'm just going to go through my research focus and the context of the research, a little bit about the background to kind of gauge an idea about the issue, the area I'm looking into, and further try to essentially identify the contribution to knowledge of this particular project. I'm going to go to just address some of the theory that's kind of formed the backdrop of the inquiry, the research. Briefly just talk about methods, and then focusing on the thematic analysis and the initial findings, with the emphasis on the initial, because I'm very early stages of my thematic analysis. And then look to the future for the implications of this, and the further exploration of this this research. All right. So the research is about healthcare professionals, but ultimately it's about the undocumented migrants. So this has been an interest for me because when I was working as a nurse in my country of Norway, I worked in two different services. So I worked in primary care, in urgent care, as well as working in a healthcare centre designed to help undocumented migrants access care. So this was a charity-run centre, and of course meeting undocumented migrants there, but also meeting them in the primary healthcare service, and eventually also when I was working in secondary care, in psychiatric care, I saw a lot of undocumented migrants in Oslo that I met in the Centre for Undocumented Migrants Healthcare, that I also met in my practice in the primary and secondary services, who for different reasons weren't able to access the services fully. An example that really sparked my interest was a woman that I met when I was working in an intensive psychiatric ward, and she got treated for a psychosis disorder. She was discharged, and the follow-up treatment of her medication was completely inaccessible for her because she was undocumented. So although she was being treated for her urgent medical problem in the secondary health services, she was no longer deemed to be needing of healthcare in the kind of follow-up stages of her psychosis. So that presented a very big problem for her, and for, of course, I was thinking for many other people across the world. So of course there's the population of undocumented migrants is difficult to quantify. This is just an estimate from 2017 that says there is approximately 5 to 8 million undocumented migrants in Europe. In Norway, we haven't had an estimate of the population which is undocumented in Norway. So the latest estimate is from 2011, over 10 years ago. And it was estimated around 18,000 people, which in a population of just over 5 million people is still a number that is significant in many ways. Most of the undocumented migrants in Norway, they reside in the capital city of Oslo, but also in other larger cities where there's more opportunity for irregular work. So undocumented migrants have limited entitlements to both primary and secondary care in Norway. And also in Europe, there is similar, even though Norway is not part of the EU, they have similar policy on access to healthcare for undocumented migrants, which is quite limited. And a study I reviewed very early on showed that there's very much a variation of the level of access that's granted to healthcare by healthcare professionals. So there was some early evidence of some implementation gaps. If you were in my health promotion class this week, you might remember me talking about implementation gaps, the difference between what we say we'll do on paper and what then we actually do when it comes to our practices. So I thought that was interesting as a phenomenon, the differences between what we're supposed to do and what we end up doing. And there's quite a lot of evidence showing that's an area of tension. So I was interested in looking further into that specific issue. So I looked into the policy or the current regulation for access to healthcare for undocumented migrants in Norway. And the services are only available to persons with legal right to residency in the country. Of course, the Norwegian healthcare system is quite universally formed, as in the healthcare services in the UK, with some minor differences. Undocumented migrants, however, are only secured the right to healthcare that's considered to be necessary and urgently required. So specifically in the legislation, this means that undocumented migrants can only receive healthcare that if it's postponed, it will cause a risk of sudden death, permanent disability, serious injury, or severe pain. So that's kind of the guidance to physicians and other healthcare professionals working under this regulation. So it really is a legislation, a regulation that prohibits undocumented migrants to a full use of primary, secondary specialist healthcare services, including preventative care in the communities, care for long-term illness, and medical and surgical procedures, and of course, hospital admissions. Anything that doesn't fall under the necessary and urgently required categories. And of course, this might be health issues that are non-communicable health issues that are chronic, such as some types of cancers, diabetes, pain and musculoskeletal issues, and mental illness. So if the health services decide to provide treatment to undocumented migrants, they have a responsibility to charge quite sizable fees of the undocumented migrants. So they are able to access the healthcare system without any legal repercussions of reporting, etc., but they would have to pay quite sizable fees to access them. So undocumented migrants are protected by some legislation, for example, in the Communicable Diseases Act, which sets out that for any communicable disease that is deemed a threat to the public health, such as tuberculosis, HIV, there is a duty to treat and take care of undocumented migrants in the country. So there is an ambiguity of legislation creating somewhat of a legal vacuum for undocumented migrants. All of these kind of intentions in the regulation, how does it translate into the practices of healthcare professionals confronted with the reality of undocumented migrants seeking help in their services? So my main kind of focus, my main question here was, how do healthcare professionals in Norwegian primary healthcare services regulate access to healthcare for undocumented migrants? So that was my kind of main question that I wanted to find out about, and my question is very much focused on the supply side of access, the healthcare professionals making these decisions, because I realized that that was an area that was quite under-researched. So I set some objectives of my research that I went a little bit back and forward with, trying to identify the kind of particularities of my inquiry. I found quite challenging. So firstly, I wanted to examine how healthcare professionals understand and interpret policy on access to primary healthcare for undocumented migrants. So do they know about the legislation and the policy? Are they aware of it? How do they read it? How do they make sense of it? Further, to explore the decision-making processes that happen in the services, and to examine how access issues are dealt with in the practices of healthcare professionals and within healthcare organizations, different sites. And finally, to understand how healthcare professionals affect equity of access to healthcare. So equity of access means, there's different definitions of this, but one definition is equal access for equal need of care. So I was interested in how the healthcare professionals and their attitudes and their beliefs and their practices and their norms affected the end results of the undocumented migrants accessing care or not, and ultimately how that affects their health. So I found there was a definite gap in the literature. So when I proposed my research, for those of you planning to do your doctorate, you would need to provide a proposal, and you'd have to tell the people interviewing you or reading your proposal why you should do this study. And it has to be something new that isn't kind of investigated before, and you also have to explain why there's a gap that you need to fill in terms of knowledge and understanding. So understanding how individual and organizational practices in healthcare organizations ultimately affect equity of access for undocumented migrants in Norway was something that is not researched in any scale. The only small-scale quantitative survey that has been done on this over 10 years ago showed some interesting results that were never kind of followed up on. The study applies traditional access theory to a more dynamic and topical and challenging healthcare and health policy problem. How do you deal with access, and how do you apply access theory to a category of patients that really fall in between kind of different categories, and they don't really fit into any of them? So that was a kind of a distinctive kind of issue of this research. And ultimately, the research aimed to provide evidence and knowledge on how UDM are dealt with in the practices of healthcare professionals to influence policy towards a more humane approach to access to healthcare, based on Norway's ratification of the United Nations human rights, and in particular, the human right to health. So some of the kind of the backdrop of this inquiry involves some theory and some kind of awareness of the kind of concepts behind my inquiry. So thinking about health as a human right, and as I mentioned, the acknowledgement of health as a human right is acknowledged in many EU member states and European countries. Everyone has the right to a standard of living adequate for the health and well-being of himself and of his family, including food, clothing, housing, and medical care. And of course, I'm kind of posing this with a famous quote from Theresa May, cited in The Guardian, about the hostile environment. So she said, "We want to make sure that only legal migrants have access to the labour market, housing, bank accounts, and driving licenses. And this is not just about making a more hostile environment for illegal migrants. It's about fairness." So it's an interesting quote that is kind of introducing fairness as a concept to a very exclusionary practice in the treatment of very vulnerable people. There has been, since I even started the project, there has been an increasing skepticism towards migration and undocumented migration in particular across Europe and North America. So terms like illegal migrants, illegal aliens are kind of terms that are being used interchangeably to describe this group. So there's some access theory that I've been working on, trying to identify how this could be applied to my research. So there's a number of theories. I'm not going to go through them, but these are some of the theories that I've used to kind of inform my research and to create kind of the theoretical framework for which I will kind of analyze my findings through. So of course, I'm interested in the issue of access and how access is realized, how services are utilized, and in particular, I'm interested in the supply side of access. So if you think about access, is essentially boils down to two things: the person seeking care and the person that is responsible for kind of opening the door to care, the gatekeeper or the supplier of care. So because I found so many studies addressing the demand side, i.e. the experiences of undocumented migrants in their seeking care, I was interested in the other side, which is the supply side of access. So what I found interesting in the access theory in particular was this theory from Frank about an degree of adjustment between the characteristics of the healthcare resources and those of the population within the process of seeking and obtaining care. So how does that kind of adjustment work in practice? How do we adjust to the particularities, the characteristics of undocumented migrants? And further use of behavioral theory from Anderson on how behavior individuals affect healthcare access and utilization, and looking at specific barriers and facilitators for access to healthcare. And what I found in kind of reading about this topic in the very early stages was that there's a lack of application of access theory in particular to undocumented migrants and researching undocumented migrants. So I found myself in a good spot to do something about that, I thought. So a little bit about my method. So this is a qualitative study. Which means it's a smaller scale study. It has a phenomenological approach, which basically means that it tries to uncover some kind of meanings and experiences behind a particular phenomenon. So I use semi-structured and focus group interviews with healthcare professionals that were involved in regulating access to healthcare in primary care services. So I did some purposive sampling of healthcare professionals, registered my criteria, registered in the Norwegian Registry for Healthcare Professionals, and those who are currently working within primary healthcare services. Those were the participants I was interested in finding, and I did a little bit of snowball sampling. I was working, to access participants as a very vulnerable point of my research, and spent a long time negotiating access through various means, and ultimately had my research approved by the ethical board of the university and in Norway. I looked into different kinds of primary healthcare services where they are likely to meet undocumented migrants. General practice, urgent care centers, which is kind of like an A&E, but it is based in the primary healthcare services. It's run by the local authorities. And public health clinics or family health clinics, and based in larger cities of Norway, where UDM tend to concentrate. So I use data mapping out where we think and estimate, where we estimate that undocumented migrants reside, and use that to find areas to talk to healthcare professionals. So I knew that I will be talking to people who had some experience of this. It is not a huge phenomenon by any means, so I had to be very purposive in how I found my participants. So this is a list of some of the participants and their kind of qualifications or their job titles. So health secretaries is maybe there's some other Norwegians in the room. They're a kind of a healthcare assistant mixed with receptionist, but they're an acknowledged healthcare professional in the Norwegian registry. Healthcare assistants, or what we call assistant nurses, receptionists, nurses, public health nurses, midwives, physicians, general practitioners, nurse managers, and section and ward managers, and clinical training leads who are often nurses. So those are the kind of healthcare professionals I talk to who are all involved in the regulation of access to healthcare. Okay, I'll speed it up a little bit because I don't want to go on too much for that. Any dialogue from and feedback from you all. So a method of analyzing qualitative data, there's several. A very common method of analyzing qualitative data is through thematic analysis. So basically using this approach to identify and analyze trends or themes in qualitative data. So it could be a theme, could be something that captured something that seems significant or important, and something that kind of is recurring within the data sets. That's the essence of thematic analysis. And the Brown and Clark approach describes it as being closely, it's a theoretical approach to thematic analysis, being closely connected to research questions and theory, and using that to help form your themes and patterns. So it's a flexible way of analyzing qualitative data. It's a very often used and sometimes criticized also way of analyzing data. And it is not particularly well defined or kind of delineated within the other forms of qualitative analysis that you could engage in. But it has the ability to make sense of large sets of rich data. So after I transcribed my data, my interviews, I then started my thematic analysis. So these are the 6 stages of thematic analysis, and I'm currently only in stage 1. So because I'm still familiarizing myself with the data, I will only present what I kind of can call my initial findings. With the blessing of my supervisors, I was allowed to say initial findings because I don't want to be too presumptuous and say that you know, I found everything and I found the answers already, because this is a process that takes some time, some refining, and some reviewing. But these are the general steps according to the Brown and Clark method. All right, so as I said, this is the kind of phase 1 of the thematic analysis, the familiarization of the data, getting to know the data, trying to find out what is interesting about my data, what stands out. So the findings represented here doesn't represent the completed themes for my thematic analysis, but they represent what's important, interesting, what I found noteworthy. And of course, also when you engage in the interview yourself and you also transcribe your data, you get a very closeness to the data, which is very invaluable for me. So when you do maybe large scale studies, you'd have someone do your transcriptions for you. I didn't have that benefit, but in a way that helped me in my kind of my grasp of my data, because you're listening to the voices, you're listening to the pauses and the laughs and the richness of the data, things that you try to convey in the text through your transcriptions. So firstly, what's interesting about the data? Well, I think it's very interesting, but what could be interesting on kind of a broader scale? So this includes discussions, wondering, pondering ideas, and accounts of experiences of a wide range of healthcare professionals. And it really highlights issues, experiences, and concerns that haven't really been attempted yet to record or to be analyzed. So it's special in the way that it's novel, and it covers the ground that hasn't been covered before. And when I talked to my participants, I realized that they had so much to say about this. Of course, we have to take into consideration who comes forward and kind of our limitations of our studies, who comes forward to participate in this kind of study. But I was still quite surprised in the richness of my data and how much the healthcare professionals were invested in this issue, considering the small scale of it, really. So the interviews are quite exploratory in nature. I had to do one interview first and to test it out, and living in this country for over 10 years, going back to my country and trying to make sense in an academic way in Norwegian was quite difficult for me. So when I did my pilot interview, the person I interviewed, he said, "I'm sorry, your questions, I don't understand them. You're speaking like you're speaking too complicated. Your wording is off." So I had to go back and review my Norwegian grammar, come back and ask questions that really teased out meaning a little bit better. So that's definitely a very reflective process. Okay, so let's move on to some of the initial findings. So some key initial findings, I kind of group them into little themes, although remember that they're not my final themes. So attitudes and beliefs, I found kind of a recurring thing that this seems to be a key factor in decision making, not very surprising. There was definitely a belief in the group that I've spoken to across all of the different genders, the different job titles, education levels, experience, that health is a human rights. There was judgments made on the merit of the patient and the need for equal access, for equal need, similar to what Mooney is represented in some of the literature. So one quote was, demanding payment has got nothing to do with my job as a nurse. So there's a refusal responsibility for the financial factor that comes with care. So just to, because we're in the UK context in Norway, the care is not free at point of care. It's not entirely free. You have to pay a fee, usually around £20–25 to access general practitioner, to access urgent care, etc. So it's not entirely free. There was a definite trend of positive attitudes toward undocumented migrants in the participant group. And of course, again, we have to consider that in light of the sampling and the persons that come forward to participate in a study like this. But that was a definite trend. This is also echoed in some of the larger scale studies that's been done on attitudes of healthcare professionals towards migrants and undocumented migrants. So knowledge was important for me. It was part of my research question. How do they understand and interpret policy? There was a lot of variation, but I would say most of my participants had a very good grasp of the entitlements of undocumented migrants. Many of the participants said this quote, they have the right to urgent and necessary care. And I thought that was so interesting because it was word for word what is said in the legislation. It's a quote from the legislation. So it was interesting to see them use that exact language. Even those who claim to have no knowledge of legislation, they tended to repeat this quote. There was some areas of particular uncertainty, gaps in their kind of knowledge, which included payment, the kind of payment, the level of payment that they should take from the patient. Should they take the normal payment, small fee, for those who are part of the national insurance program, i.e. citizens? Should they take the kind of private patient fee? Can they refer to secondary care? Do the patients have any entitlements to social and housing support? Some of the participants, they claimed that undocumented migrants had no entitlements, and they were quite sure about this. But they explained further that they were still and are still offering full ranges of services to them regardless. Here, they were citing their individual beliefs, their attitudes towards migrants, and health as a human right. Okay, I'll speed it up a little bit. So pragmatism, I think, just was something that jumped out of the pages for me when I was reading my transcript. So pragmatism, doing things in a way that's practical and not necessarily by the book. And the reasons for doing this was quite multifaceted. There was definitely, because of this, a lack of a consistent approach across individual practices. A recurring theme was an emphasis of autonomy, freedom, and the responsibility of individual practices. So my participants will often say, well, I will do what I think is right. It doesn't really matter, what the policy of the legislation say. So there's definitely a sense of safety within the system of work in Norway that perhaps is quite unique. It's obviously linked to ethical codes of practice, but also being a worker in Norway is a very safe space to be. You have very high degree of rights. a high degree of autonomy, low degree of managerialism, a very low emphasis on rules and compliance comparably to other countries. So I think that's quite unique. I try to probe this, say, well, what happens if you do this and what you're not supposed to be doing? There wasn't any real ramifications or consequences, or at least not any fear of that within the healthcare professionals. So prioritizing undocumented migrants, many of them cited this kind of public health argument that we've seen a lot when we advocate for universal access of care. So who else will help them? Or if we don't help them, especially in arguments seen in the urgent care services, if we don't help them here, the problem will grow, become more severe, trickle down to, for example, ambulance services, secondary care, more costly services. So they were facilitating access based on need, equal access for equal need, as Myhre says, and is the definition of equity, and not formal requirements of the system, not tick boxing and following the book. And they're also adjusting themselves. Remember my frank quote about the degree of adjustment. So they were adjusting themselves to the needs of the patients rather than kind of blindly following the rules. All right, so final slide on my findings. So I was interested in also what was going on in the organizations as per my third research question. So the organizational practices, there was different sites that set various standards of practice when it came to access. So participants were referring to norms of the workplace. You know, we do it like this, but you know, that's how we do it here. And that was quite different across different sites. In particular, the urgent care centers that I visited had the most lenient practices. And they told me that they're used to seeing a lot of social need. They're used to dealing with very vulnerable people, and they have kind of a high degree of pragmatism in their work. Dissemination of information on undocumented migrants' access to healthcare seemed to happen quite informally through word of mouth, and usually wasn't part of formal training in any of the organizations that I visited. And if it was, there was a lot of variation in the degree of awareness of the formal procedures within the organization. So again, it kind of harks back to this idea that they will kind of do whatever they want anyway, even though they have these sets of rules. And finally, language and communication was something that could act as a barrier, impeding access to care, both on the side of undocumented migrants understanding their own rights, but also barriers to healthcare professionals understanding what UDM are seeking help for. So there's individual kind of predispositions there in the level of care and interest that the healthcare professional would invest in the patients, and resulting in the kind of care that they would receive. So just to sum up, this research is in progress. These are my initial findings, and they're not my finished themes of my work. The findings are in congruence with increasing kind of NGO organizational pressures on government to provide more comprehensive entitlements and coverage. There is seems to be a great deal of will among the small-scale qualitative sample of healthcare professionals here to provide comprehensive coverage of healthcare. And I'm interested to seeing how my themes turn out. And of course, this could provide a basis for a larger quantitative or qualitative study into policy implementation on a national scale. All right, so that finishes me in about 40 minutes. Sorry, I was going a little bit over there. And thank you so much for listening.
Thank you very much, Maja. So many interesting themes there, and definitely ringing a lot of bells for Maria and myself, because at the moment we're doing a piece of research, Bodies at Borders, which very much speaks to the whole hostile environment, We're currently working on a project with Afghan migrants and refugees. In fact, yesterday we spent the whole day at an Afghan association interviewing people, many of whom are sort of currently in that limbo position where they're sort of waiting in the very protracted asylum process with all sorts of uncertainties around their status. So this is all very pertinent to the kind of work that we're doing at the moment, and many colleagues in the Global Diversities and Inequalities Research Centre are currently doing. So lots of food for thought there, and it's interesting to hear the Norwegian case, because I think here we often think of Scandinavian countries as being so much more progressive than the sort of Theresa May hostile environment that we've been confronted with here for the last 10 years or so. So it's interesting to see those observations that you're making in your important research. So I can invite colleagues now to type their questions in the chat or to put up their hands to ask their questions. I think, Maja, you've made it very clear that you're at a preliminary stage in the analysis.
Yeah.
So these are not your final findings. But I wonder if anybody does have any questions. Maybe it'll take people a moment or two to formulate their questions. You can type them in the chat. You don't have to type laboriously in the chat. You can just put your hand up and we'll invite you to turn your microphone on and ask your question. So do we have any questions yet?
If there is not any question, Louise, I can do mine. I can make mine while colleagues and people
Absolutely.
do that.
Yes, please go ahead.
Yes, Maja, that was very interesting, and your research is really, as Louise says, very, very interesting and very relevant to our own research about migrants in the UK. In the interviews that Louise just mentioned, some participants, many of them actually, they made reference to the language barrier. They don't understand the regulations in this country and they're completely lost. Many of them, because we asked them, what would you recommend to those people who just arrived, and what would you recommend to local authorities and to local government and the government to do? And they all made mention of that sort of flyers and reinforcement in that communication side. Did you have the chance to conduct some research on the language barrier, which is the main thing for many of them, and it's quite strong complaint and very powerful complaint from them in relation to your own research, because you mentioned that very briefly in one of your slides?
Yes, definitely. You know, when I was doing my kind of literature review and researching into the barriers of access, that really came up consistently as a problem, and in particular in you know, those meetings and making oneself understood. I think that's so significant, because obviously we're working in increasingly kind of pressurized environments where we have to go, and of course also the understanding of the entitlements and the importance of non-governmental organizations, charities that work in advocacy and supporting the undocumented migrants from the side is so important. And you know, I just know from my own experiences working with undocumented migrants and providing clinical care, you know, that often there was a trend of kind of somaticizing illnesses. So, for example, I remember so vividly this man who came in to me many times and asked for consultation. He said, my arm hurts in this very particular spot, and it was just so strange because nothing in my clinical kind of understanding could explain this kind of pain. And what I realized that he just had that kind of, he thought he needed an excuse to talk about, you know, his life and his difficulties, and he said, okay, this hurts, and then, you know, that was an entry point for him to come and talk about other things. So I really, you know, I really understand, you know, I've seen that and the language, and I think if we can equip undocumented healthcare professionals with a good understanding of the entitlements, then we will help undocumented migrants who don't have that agency, who don't have that power. So ultimately, you know, that's a big part of this is you know, that kind of that belief that I have, of course, about healthcare should be a human right, and that's really central here, that we create that kind of supporting environment around the undocumented migrants.
So you would definitely increase the budget for translators and interpreters. And
Yes.
we just make that link, and also
Absolutely. Yeah.
That's great.
So maybe I can jump in and ask about the kind of conceptual framework, because in the work that we're doing on Bodies at Borders, we're using Myhre Yuval Davis's work that she has done with colleagues on everyday bordering, and the way in which, you know, this concept talks about the fact that we think about a border as a hard physical border at Dover or Calais, or, you know, something, a hard physical spot that divides two countries. But Yuval Davis talks about everyday bordering as an ongoing process where migrants, particularly undocumented migrants, continually meet border guards, and a border guard can be a nurse, a border guard can be a teacher. Here in this country, for example, landlords now have a statutory obligation to be border guards. So a landlord cannot rent a property to somebody without checking their status in this country. And if a landlord does rent a property to somebody who then subsequently turns out to be undocumented, the landlord can be fined massively. And there was actually a suggestion here in the UK that this would be introduced for healthcare providers, and there was a big pushback against that. Though I think it is only, again, for certain kinds of healthcare, like if you're about to go into labour, then there is a statutory obligation to provide that care, whether or not you are an undocumented migrant. But it's this kind of framework around the everyday bordering and this continual placing of checks on people's immigration status, as access to education, as access to healthcare, as access to even the basics of renting a property. And I wonder how that translates in the Norwegian case, whether healthcare providers feel a sense that they are now expected to be border guards. Did you come across that in your work, Maja?
Yeah, thank you, Louise. That's so interesting, and I've read this. I've read on the everyday bordering by Yuval Davis. I thought that was very interesting, and very interesting in the Norwegian context as well, which is slightly different in terms of the demand that we put on healthcare professionals and the expectations. So there hasn't been any attempt of that kind of a policy, but also when I try to gauge, you know, the feeling, are you a gatekeeper? I think I even asked that question, do you feel like you should be gatekeeping this service? Do you have a responsibility? No, we don't. That's not our job. So there's a definite refusal of that. And again, the kind of the key kind of trend that kept on coming was, this is about healthcare, everything else doesn't matter to me. But of course, by saying that, they're saying something essentially very political. You know, that is extremely political. They're claiming to be apolitical, but of course they're making a very political statement there, that, you know, that is, we are a universal service, even though we don't have to be. So I think, again, I think that kind of harks back to the particularities of the Norwegian system, where you have a very secure kind of system of work, where people feel extremely secure in their work. I've worked in the healthcare services in this country, and I definitely haven't felt that. So I think there's a system of protection around healthcare professionals, perhaps, that allow them to act this way. Sorry, Louise.
But that's a really interesting point around autonomy and the extent to which healthcare workers feel that they have the autonomy to make these decisions and to provide care without having the pressure of this kind of legal immigration bureaucracy pressing down on their shoulders. So that's, I think, quite different from here. And I suppose it's inevitable that when you're presenting your work that people will ask you, and how does that compare to here? Because we are here, and this is the context in which we're most familiar. So it will be very interesting, I think, when you finish your PhD and you're thinking about publications, to maybe plan a publication which compares the different requirements in the UK and in Norway, and how that immigration regime impacts upon those decisions that healthcare workers make on a day-to-day basis. So really fascinating. So I'm just wondering if there are any other questions. We don't want to extend the discussion so that it's just Maria and I throwing questions at you. Does anybody else have any questions? There's 30 people in the room, so perhaps if you're shy, just put up your hand and you can ask your question. You don't have to type it. Or if there's anything else from the data that you'd like to share with us, Maja, as we have a little bit of time left.
Yeah, I was just reading through the chat to see if there was anything. No, you know, obviously I think some are moving to other meetings, and I guess it's that time of day. But yeah, I guess I could, you know, make some kind of concluding remarks about, you know, because I know there's some students here and colleagues, of course, and supervisors, etc. And you know, we mentioned in the beginning before everyone joined about, you know, the journey of doing a doctorate, and I think many would know the challenges of that, and if you don't, you know, trust me, it is challenging. You know, I think the what's kept me going in this is a very strong kind of personal interest and belief, and really a kind of a passion for this field. And it's been interesting to see how my topic has become more and more topical as, you know, I've worked in this, and I did my master's at London Met, and Livingstone Musoro was my supervisor then, and he's my first supervisor together with Justin Webb now. So when we worked on that in the very beginning, when we worked on that in my master's, you know, it was kind of you know, I didn't really understand it fully, and looking back in my work now, I think, gosh, what was I doing? You know, it wasn't, you know, in any way perfect, but it was the start of something that has become more and more important. And I think, you know, as researchers, we have to grab onto those kind of those important moments, those kind of Overton windows, and see, you know, this is the time to talk about this. So you know, and of course, you know, it's an intersectional kind of work where, you know, you tap into health, but also social policy, and also kind of sociology and other kind of concepts. So kind of situating myself as a nurse in such an academic discipline has been really challenging, and I think for those other people that are clinicians, they recognize that as well. So yeah, I'm excited for the way forward. And thank you so much for listening.
Well, thank you so much, Maja. It was really interesting, and as I said, it was very close to the bone for myself and Maria, because we're steeped in all of these issues at the moment with our new project on Afghan refugees. So so many parallels there with what you're describing from the Norwegian case. So very, very interesting for us, real food for thought. And the very best of luck with your PhD.
Thank you.
Really such an important topic, and as you say, so timely and so political as well. It's a very important piece of work, so the very best of luck with that. And we hope that maybe next year, when you've finished, you can come back and give us another presentation with your findings, with your fully developed findings. We'd be very, very interested to hear that as well. So the very best of luck. Thank you very much. And can I just remind everybody that we have more seminars coming up in the series. Our colleague Anna has very kindly put them on the website. There's a link in the chat. So please do come. Thank you very much. Anna is reminding us that we've got a seminar on the 9th of March on universal income, which I think will be very relevant, another very topical issue, which is in the news a lot at the moment. So thank you very much. Thank you, Maja. The very best of luck with finishing your PhD.
Thank
and
you.
We hope to see you all again very soon at another seminar. Thank you.
Both.
Bye.
Bye,
Bye, everybody. Bye.
Bye.